Thank you. Thank you so much. And thank you everyone for, again, attending at the end of busy days. I know it can be hard. There will be a couple of polls that I'll ask during the webinar, just two, with very simple questions, which have a yes or no or one word type of response. And if you could type those in as well into the chat to see if everyone's happy with what we're covering along the way. And basically, the idea today is just to go through the cases that we've seen in the practicals, so that you have those notes for the future. So we're going to look at the different cases so that you can compare with the notes that you took during the practicals to see if you've got the broad ideas or not. And while we're doing this, we'll go through Bayesian approach of how we evaluate cytological samples, looking at different points that will be reinforced in different cases, just to say why that's important. But generally, these principles apply to all samples. And remember, cytology takes practice. So try and use it to identify the common things and the important things, and then build up your skills by sending those cases as you go. If you think about imaging, it's the same thing. You can't just put a probe in and look at the liver and say immediately what it has. It takes that practice, and it's the same with cytology. So don't give up on cytology. Okay, so the first case that we had was a brownish, turbid, flocculent fluid, and different types of fluid on macroscopic appearance will require for you to do different smearing techniques of those fluids. So it's really important to reinforce this idea that you can't just do the same technique for all sorts of fluids and get the same quality of samples. So if you have really, really turbid fluids that you can't read or see letters across those fluids, or if they're bloody, then doing direct smears, the same technique as you would for a blood smear, is the best way to do a smear from that fluid. And remember that even if you are sending the fluids to an external lab, it is worth doing that smear fresh, to send along with the fluid for the external lab, because as I mentioned during our time together, there are a lot of changes that can happen once the fluid is outside the animal that may mimic disease. So it's important to do that fresh smear. So for turbid or bloody fluids, we do a direct smear, same technique as you would for a blood smear. If it's just mildly turbid, so you can see the turbidity, but you can still see across the fluid, then we should do a line smear, which is a concentrating technique. And if they're clear and transparent fluids, they're not turbid at all, and we can read across them, then doing a sediment of the smear or doing a cytospin preparation, if that's available, is the ideal way. I have here a little video that just shows that approach to this fluid. So we always start at the edge of the fluid, and we're trying to get it into focus. Then we, like we do for the blood smears, we bring it back in to the body of the fluid where the cells are trying to spread out, and we're looking for that monolayer, the same as we would in a blood smear. Okay, so from a low magnification, I'm just scanning through to see if there's any differences or if I have the same in every single field. So it's important that we do that scan and that we don't make the mistake of going straight for the oil and get too excited saying, "Ooh, there's cells, let me look at those cells." And it's really important that we're looking for where these cells are well spread out, but not ruptured. You see all of those streaking cells that we have here? These cells are ruptured. It won't be good to look at these cells. Okay. Now, when I'm looking at these fluids, again, looking for that area, this is before I put into the oil. So I really want to put into the oil. This is me going into a bigger magnification to assess what type of cells we have. And so here I'm asking the question, not just are the cells okay and well preserved, but what kind of cells they are. And sometimes I even have to go to a greater magnification in order to be able to establish. So here I'm putting in my drop of oil and I'm allowing the microscope to refocus. And now I can identify these cells much better and say what they are, okay? And again, and we'll look at several fields for these cells, and to see, I might go even to a bigger magnification to see if there is any content. So this is with my 1000 magnification. I'm looking here very much at detail. So do I have granules? Do I have bugs? Do I have nuclear detail that is important, such as nucleoli and whatnot? So in this case, okay, what we had is really high cellularity smears. So we had lots and lots of cells to look at. And these cells were well distributed, so they weren't all clustered in one place. So they were all well distributed. And often they were well preserved. So there were areas where the cells were really ruptured and dragged, and we cannot look at ruptured or dragged cells. We really shouldn't be looking at those types of cells. So areas that are too dense, we should be avoiding as well. So we need to remind ourselves to look at that monolayer, to look at the fried eggs where the cells are really well spread out and separated. And so here in this field, I'm going to ask you to think, what are these cells? Okay, so I'm going to put here a circle. Think, what is this cell? Okay, and I'm going to point to two other cells here. I'm going to ask you guys to think, what are these cells and what do they mean? Okay, so let's go for the poll number one. What are the predominant cells here? What do you think those cells that we saw in that first case were? Just give it a little time for people to type what they think those cells were.
Okay, you're going to have to bear with me when it comes to the pronunciation.
That's fine.
So a lot of people are saying neutrophils.
Absolutely.
Yeah.
Neutrophils, absolutely. They were all neutrophils. And again, just reinforcing, whenever I think of neutrophils, I think of Elvis. So the question is degenerate or non-degenerate. Just put D or N. D for degenerate, non-degenerate, put an N in. What do you think about the cells we saw?
I think a lot of people are saying degenerate.
Yeah, absolutely, degenerate. There were some that were non-degenerate as well. And as I mentioned, that these, when we have degenerate neutrophils, they don't always are all degenerate neutrophils. Some of them will be non-degenerate. So when we see signs of degeneration, it's what would be the likely causes? What do we need to go and look for? More typing.
Okay, so people are saying bacterial infection,
Yep.
inflammation.
Yeah. So microorganisms, bugs, absolutely, and bacteria will be at the top of the differential. But remember that you can have sterile causes for degenerate neutrophils. And the most common is toxic environments, such as the presence of bile or the presence of urine. And so just think that if you do have an abdomen, for example, with a fluid that is full of degenerate neutrophils, if you can't find any bugs, then think, can I have a uroabdomen or can I have a bile peritonitis type of thing? So in this case, there were lots and lots of bugs, okay? So there's several pictures that here that show that again, indeed, there were degenerate neutrophils. We had them with a more open, ragged chromatin, much lighter in color. Okay, some of them have vacuoles. The neutrophils had vacuoles, like we can see in that one, and in that one, there's little vacuoles there. And then we had actual organisms inside the cells. So it's really important when we're looking at this that we're making sure that there are really organisms in there inside the cells, because that is the definition of sepsis, is the organisms have to be within the cells. But these, you could see several fields, and there are different types of organisms that could be found. And they were also present in macrophages, not just in neutrophils. And some of these cells are really difficult to identify as being neutrophils because they're so degenerate, while others we could more easily identify as being neutrophils, such as the one I'm arrowing now, or the one here in the left-hand top corner, where it's more easy to identify as being a neutrophil, even though it's degenerate. I also like to point out that we had these more thin, long bacilli that had what we call a beaded appearance, where we have the dark light, dark, light, dark, light, that you can see on this. And this is called a beaded appearance. And that's a morphology that is typically associated with anaerobes. And this, because it's inside the neutrophil, again, we're saying that's highly significant. And there were actual areas where we were seeing almost entire bacterial colonies there was almost more bugs than cells. So again, these really long branching bacilli are typical morphology for things like nocardia or actinomyces, and they might need a different antibiotic therapy. So we have to keep those in mind. So one of the most important questions that we face when we have neutrophilic inflammation and stuff inside the neutrophils and around them is this bugs? Is this a septic neutrophilic inflammation, or is it just something else around the neutrophils? And it can be hard to distinguish bacterial microorganisms from things like stained precipitate or cell debris. But we have to remind ourselves that organisms are often very regular in shape and size within the same organism. So obviously a staph will be different from a strep, that will be different from an E. coli, but they tend to be very monomorphic when it's an organism, so they'll have the same size. While cell debris tends to be very variably sized. Again, the organisms tend to stain with our DIFQuick very, very dark because it's almost everything is nuclear material. And it's really important that we're identifying these in the same plane of focus that the cells are, so not in a different plane of focus, and ideally within them, inside the inflammatory cells. That is what defines sepsis. And again, to remind ourselves that stained precipitant often shines when you go in and out of focus. So when you play with the focus, you will see that the stained precipitate tends to shine, and that's often a good indication that it's not an organism, that it is stained precipitate. Remember, not all that shines is gold. So identifying sepsis is one of the most important cytological skills in practice, and this is because it has a clear impact on patient management. So for case number 1, we had a septic neutrophilic exudate, so it was a typical pyrothorax. There were lots of degenerate neutrophils with intracellular bacteria, and we had as well lots of macrophages with intracellular bacteria and cell debris. We had different types of morphological bacteria presence. We had cocci, we had bacilli, and we had that morphology that suggests the presence of anaerobes. Obviously, in a pyrothorax, you would always consider the possibility of anaerobes being present, but it's a good idea to consider that when we see that type of morphology elsewhere. So that was case number 1. So I'll just very quickly ask if there are any questions on this. Because if not, we'll just move on to case number 2. No?
Okay, no, can't see any questions.
Okay. So case number 2 was also a pleural effusion. And in this one, we had the cell count. I forgot to say that in the previous one, we didn't have a cell count because it was flocculent. And when we have flocculants, when we have pieces of chunks of material within the tissue, we don't want that to get near our hematology analyzer to provide us a cell count, because it may well clog it up and leads to a lot of headaches in times to trying to get it back to normal. But with case number 2, we had a cell count. So we knew immediately from this high cell count that we had an exudate. So we had a fluid with a high cell count, exudative process. And again, with this fluid, we had the cells were unevenly distributed. And because of this, when we looked at that body of the smear, we could not find that many cells. We could see that there was a really pale eosinophilic background, which is consistent with a high protein content. We could see some red blood cells as well, and then just some scattered cells that were seen isolated just as a single cell or in small clusters of very few cells. So this is just an example. Again, it's a direct smear because it looked like a going to be an exudate because of the cell count, but because there weren't that many cells, we then did the line smears for this case. So just going here very quickly to demonstrate that in the body of the smear, although we could find some scattered clusters of these cells, it was only when we looked more towards the line smear that we could see a really high number of these cells in a concentrated space. And it was so thick that in some areas it had been washed off by when we did the staining. And that's fine when those big chunks of material are washed off, because they would have been too thick for us to look under the microscope anyway. So in this line smear, again, against all of the smears, and we can do this also at the edge, at the lateral edge of the smear, we are going to see this concentration of the cells that are heavier and that they are of interest. So in this line is where we're going to look at the morphology of these cells and be able to assess them a little bit better to look for morphology changes. So this is me again putting on the oil and trying to assess these cells in terms of how are they aggregated and what are their cytological criteria. How are they identified? Are they, tissue or inflammatory cells? Do they have nucleoli? All of those questions. Are there organisms is what I'm trying to answer at this magnification. So this is again the concentrated idea of the line smear. It makes much easier. The other thing I wanted to say is when we have those, for example, those septic exudates that we had in the previous case, in the top layer on that lateral edge, when we have good intact cells, this would be a good area to look for the bugs. That's one of the areas that I often go and look for bugs, where they are well spread out, but still enough. So this case is another one that points out a common mistake that people often do when they're starting with cytology, which is to go straight for the oil magnification, look at all of the smears. And there was a couple of people that, even though I'd pointed out during the practical session that it was a line smear, that still tried to look at these cells in that middle area. And when you have these concentrated, it's a good idea to go and look there and look at the area. So these cells in this concentrated area are the same as in the body of the smear. They're just more to look at. So you'd spend far less time to examine a lot more cells. Because they were present in this isolated or in these three-dimensional clusters, and they were also seen in the body of the smear and in the line area the same. And this type of clustering of these cells is very typical of an epithelial population. So the fact that we're seeing these, not just the isolated ones, but the really three-dimensional clusters and aggregates of these cells, that's typical for epithelial. And I know that we were also seeing them discretely and seen as in isolation, but not the fact that we're seeing cells that are round doesn't mean that it's a round cell tumor. I think that's one of the reasons why we stopped calling them round cell tumors and started calling them discrete. Okay, because it's the arrangement of the cells that will make that that decision a little bit more easy to do, rather than just are they round or not. One of the things that I would like to point out is just the sheer size of these cells. So remember that we always look to red blood cells and neutrophils for size comparison, and these neutrophils are condensed, so they're not really spread out, but still we can see that these cells then are very, very large cells compared to the neutrophil. And when we have to look at this background here as well, that it's got that kind of fine stippled background that is pink or eosinophilic, and that means that this is very rich in protein. So I know that this fluid's going to be rich in protein. So just a couple more examples of how the cells are then not just in isolation, but in these really thick three-dimensional clusters. And that's very typical for epithelial cells. So the arrangement of the cells, the architectural patterns that the cells form amongst them, are what help us identifying the three main groups of tissue cells. So the discrete that used to be called round cells, the epithelial origin, or the mesenchymal cell origin. Another of the things that really I'd like to point out, it's very, very typical of the epithelial population, is the presence of these very clear defined cell-to-cell borders. So here we have to really go and increase the light in these thick clusters, increase the light of the microscope to the maximum. And you can see that that background now has gone all bright and white. And it's because I'm trying to assess within these thicker clusters, how are these cells interacting with each other? And I hope you can appreciate in the arrowed, the fine white lines that are here between the cells. So all of these here and here, this is a typical thing that can assign this to an epithelial population, is that this well-defined cell-to-cell border that we call often the tight junctions between the epithelium. So then when we move to the oil magnification, we could identify several criteria for malignancy. And in fact, in these slides, you could find all of the criteria for malignancy that we've covered in the theoretical part of our session. There wasn't a single criteria for malignancy that you couldn't find if you looked hard enough. In this case, for example, we have nuclear molding, where the nucleus of this cell is being molded by this cell being here. And this is the cytoplasm, and that is the nucleus of that cell. And this is potentially a consequence of something that neoplastic cells can do, which is cell cannibalism. I love the idea where cells that aren't usually able to do phagocytosis, because they've gone so evil, they start eating up other cells, which can include xenocannibalism, so eating other cell types, or autocannibalism, so actual cannibalism, which is eating their own cell types, so neoplastic cells eating other neoplastic cells. And these were really, really malignant and evil cells. So again, just for size comparison, there's my neutrophil here that I'm circling now with the arrow. Again, for size comparisons, look how big this cell was. So here we have, again, the nuclear molding. Other examples of malignancy were macronucleoli, where, again, we have to compare the nucleolus to the size of a red blood cell. And if you have a nucleolus that is bigger or the same size as a red blood cell in size, that equates to a strong criteria for malignancy, or having macronucleoli. Just to point out that this inset here is just a magnification of that cell there, and that we're seeing here what we call cytoplasmic blebbing, so just little bubbles or cytoplasm coming out of the cell, giving that irregular outline. And again, just to point out the pleomorphism between these cells, which is again a criteria for malignancy. So having cells with different sizes, with different shapes, with different nuclear to cytoplasmic ratio. So we have cells here that are very small and others that are very big. We have cells here that have a lot of nucleus for a little bit of cytoplasm, and cells that have a lot more cytoplasm for the same size of nucleus as the other cell. And then that deeply basophilic cytoplasm that is associated with high cellular activity, and that can is a less marked criteria for malignancy, because it's a cytoplasmic criteria for malignancy, but it can get to a point where it's so basophilic that you can't look inside the cells and look at nuclear criteria. We also have different numbers and different sizes of vacuoles in these cells, including those large coalescing vacuoles that are pushing the nucleus of the cell to the side, and they're called signet ring cells. And again, these are cells that are typically associated with neoplasms of epithelial or mesothelial, because this is a body cavity fluid origin, so carcinomas or mesotheliomas. Just again, more of these Examples again with lots of the pleomorphism. I love my Mickey Mouse cell here with the two little ears and the big vacuole, making that one a signet ring cell as well. Again, having those nucleoli that are not just big, but they're irregular in shape, so they're not rounded shape, giving another criteria of malignancy. Again, lots of criteria for malignancy and of the strong kind. So when we have the nucleoli being different numbers between the cells, different sizes, different shapes, and having those really big nucleoli. Now, I also want to compare that you to think about the size of these neoplastic cells. And some of these cells were huge. Again, if we compare this cell against the neutrophil here, we can say that this is indeed a cell that has karyomegaly. So it's got cytomegaly and karyomegaly, so really big cells, really big nucleus as well. Again, we had atypical mitotics also present in some of these cells. And we talked about how that's a criteria for malignancy as well, with lots of, in this place here, so this mitosis is going in one direction, then we have lots of little pieces of lag chromatin going in multiple directions. Another example of a disorganized mitotic figure along with the same type of pleomorphism that we've been seeing in the other cells. Again, more of the signet ring cells, again, more anesocytosis and mesokaryosis. It was fairly easy to find these criteria for malignancy. At least I thought so. So one of the things that I wanted to ask is, had you seen the line smears being used before? Just a yes or no?
A lot of people have said no.
Yeah. And can you see the benefits, though, of using that technique? Were you able to appreciate that there were a lot of cells that were then concentrated and it was much quicker to look at all of those cells?
A lot of yeses for that question.
Yeah. So hopefully, again, we can start employing this new technique to making these smears so that it makes our job easier when we're looking at these slides. And then finally, were you able to identify criteria for malignancy in this case? Were you happy that we had lots of these criteria when you're looking at the cells?
Again, we've got yeses.
Good, good. So then we're happy that we can identify things when they're really evil, and we're happy that we can identify sepsis, and that makes me really happy as well. So let's go to case number, just summarize case number 2, which was indeed a neoplastic exudate. There were several criteria for malignancy in these atypical cells. Because the cells were arranged in the deeply cohesive clusters with those cell-to-cell junctions present and with the well-defined cellular outline, our main diagnosis would be a carcinoma or a mesothelioma. And when it is a carcinoma, it's impossible to say if that's a primary, so because this was thorax, that this would be a lung carcinoma, or it would be a metastatic carcinoma. So, for example, this could have well been metastatic mammary carcinoma, okay? So we need the imaging and the history to be able to tell us more and to differentiate more. But we are able to say that we've got a malignant neoplastic population in our thorax, so immediately our prognosis, we know that it's not going to be good for this animal, unfortunately. Good. Any questions for this case? Maybe we'll save the questions for the end and see.
Yeah, right at the end, yeah.
Okay, so case number 3 was a cutaneous nodule from a dog. It was not fixed and it was non-painful. And this case was selected on purpose because of its uneven distribution. So in the majority of the smears, we had cells that were seen isolated and discreted in a background of blood, so we could see that type of arrangement of the cells. But then in other areas of the smear, we had presence in cells that were in bigger, thicker aggregates, and they were different from the rest of the population that we were seeing. So this second population of cells, it was not so densely tight as in case number 2, but they were definitely different than everywhere in the background. So if we went straight to the oil magnification in the first areas, we could have easily missed these clusters of cells. This is something that I want to reinforce, is that we have absolutely to look at the whole slide with a low magnification, identify the different areas of interest, and then move on to the oil. and not just go straight in. Okay, it's a common mistake to go straight into the oil magnification, and you're going to miss out on important information. And that was the case certainly for some of you. So when we looked at that initial area of the smears with a higher magnification, we would have been able to identify that a lot of it was blood. So we had lots of red blood cells and platelets as well scattered. And then we had lots of cells that were in a concentration that was maybe greater than the amount of that we would have expected from a normal peripheral blood smear. And again, just to point out, what we have here is mostly neutrophils and eosinophils in this. And if we think about what we would normally see on a blood smear, we wouldn't expect to have so many neutrophils and eosinophils. So again, if I point out to this neutrophil and ask that question, D or N, is it degenerate or non-degenerate? What do you think this is going to be?
Okay, we're getting a lot of nons here.
Absolutely non-degenerate. So this tells me that this inflammation that we have is unlikely to be caused by something like sepsis, but it doesn't rule it out. Okay, but it's less likely than when we have degenerate neutrophils. But actually here we had a lot of eosinophils. And I'd like to point out that when we have eosinophils in tissues, when they move out from the blood into the tissue, they often lose that ribbon-shaped nucleus that we have, very similar to the neutrophil in the peripheral blood. And in the tissues, they assume this more bilobed or sometimes even a single nucleus, so a single rounded nucleus. But they're still easily identified by their granules. Okay, so if in doubt, one of the ways to see if they are eosinophilic granules is to lower slightly the condenser. And remember, the condenser is what is just below the stage in the microscope we saw in the practical sessions. And these will make the granules of the eosinophils slightly refringent. So you will see a small shining effect of these granules. If you're in doubt, is it a neutrophil or eosinophil? Okay, so it's always a good technique to see. So in this sample, you had eosinophilic inflammation. That was easy to identify. But when we have inflammation, you have to look for the cause for inflammation. So obviously, if we have neutrophils, we go and look for bacteria, but we can have many other causes for neutrophilic inflammation, just necrosis, immune-mediated disease. So lots and lots of causes for neutrophilic inflammation. Macrophages, if we have macrophages, we're going to look again for organisms, usually more complex organisms such as protozoal or fungi, or mycobacteria, foreign bodies, so that sort of organisms. And when we have eosinophils, we obviously have to look for parasites, but we often see eosinophilic inflammation with paraneoplastic, so with mast cells, lymphoma, and obviously hypersensitivity reactions like in the cats with eosinophilic granuloma complex lesions. But in this case, we were having all of that eosinophilic inflammation due to mast cells. So again, we had to hunt for these in the slides. They weren't like overwhelming in all of the slides. You had to go and hunt for them in a lot of the preparations. But when you found them, they were easily to identify. So they're rounded. They often lots and lots of purple granules, and they overshadow nuclear detail. That means we can't really look at what's inside that nucleus. It's going to be really tricky to identify if they have nucleoli or any of those features for malignancy. So it's going to make it difficult to identify the criteria that can be associated with the high grade of mast cells that we've described. But in cases of well-granulated mast cell tumors, we cannot grade them on cytology. So this is always a recommendation, is to follow up with a histo. In cases where we have less well-granulated mast cells with, again here, variably sized granules and some of them not granulated at all, then that can be one of the criteria that makes me think potentially this is going to be more of a high grade, but I still confirm that with the histo. Also remember that with the rapid stains, the mast cells tend to not stain the granules as well, but that means that it will be easier to identify these features that might indicate the high-grade mast cells, such as the variability in the nucleus, the different numbers of nuclei, the presence of nucleoli, so all of those. So case 3 was a mast cell tumor with marked eosinophilic inflammation, and it was put here as a reminder that cell distribution may be uneven in the lesion or the sample, so we really, really must look at all slides and all areas of the slides. Now I'll move on to case 4, because I suspect that there will be no questions for that first case, and that most people will have been able to identify that case easily. And this is another one. Case 4 should have been another easy case. And it's the type of cytological diagnosis that I believe that all of us should be able to do. And that, you know, that I shouldn't be really seeing almost in my practice, because it should be so easy for you guys to do it. Again, the majority of the smear, there was sparse material. We had a little bit of an eosinophilic background with abundant free fat droplets. Okay, you can see them like this, just empty spaces. And these are really scattered red blood cells as well that we could appreciate, but in the majority of it, there was nothing. And there were a couple of people in the slide sessions that commented that there was nothing in the sample, and again reinforced the previous point of looking at all of the smear with a low magnification, because then you would have been able to easily identify these clusters of cells. So obviously this is a lipoma case, and I hope that everyone would have been able to identify this. And it had these really dense aggregates of well-differentiated adipocytes that have the kind of rounded aspect, big cells with very small and dense oval nucleus, no nucleoli of anything like of the sort. And it's important to remind ourselves that these cells in lipomas are supported by stromal and endothelial tissues. And when we look at the greater magnification of that, then we can see that these cells are indeed not adipocytes, but they're just there as part of the connective tissue. They're supporting the tissue. So these are the stromal cells here. And these are example of endothelial cells where actually we can see some of the red blood cells inside the little vessels here in this lipoma. And this is commonly seen in lipomas. So it's one of those things that it's very frequently encountered in lipomas. So case 4 was a lipoma. Just again, remember the uneven distribution of cells. When the slides appears to have nothing, you need to definitely go and screen it with a low magnification. But sometimes with lipomas, we see no cells, just the free fat droplets. And then unfortunately, we cannot make a cytological diagnosis. So this is going to be a clinical diagnosis. It looks like a lipoma. I only got fat out, so I'm going to make that presumptive diagnosis. Also, I'd like to point out that you have exactly the same picture when you aspirate a really chunky piece of normal body fat, of normal fat. So if sometimes we get this type of sample when we are trying to sample lymph nodes in fatty dogs, because there's accumulation of fat around the lymph nodes. So it will look exactly the same. So in order to be lipoma, we have to be sure that we're sampling a mass and that this is representative of the mass and not of the fat that might surround the mass.
Okay, Marta, we've just got one question.
Yep.
So how is liposarcoma different?
Liposarcoma, you have a picture in your slides, handouts. Liposarcoma will look like a sarcoma. It will also have the fat, but it will have the criteria for malignancy. They're often not shy in showing us that they're evil. In these cells, the nucleus are very condensed. There's no nucleoli. They're relatively regular in size and shape of the nucleus as well. It tends to be oval or ovoid and very condensed chromatin. So dark chromatin with no nucleoli, fairly regular in size. A liposarcoma tends to show anesocytosis, anesokaryosis, lots of criteria for malignancy. And I'm pretty sure that you have a picture of a liposarcoma in your handout that you've had from the practical session. If not, if it by any chance it isn't there, just pop me an email and I'll put a couple of images of liposarcs for people to compare. But it looks very different, even though macroscopically. So when you aspirate from the animal, it can come out looking as fat. And there's also the possibility that when you aspirate something that looks like a lipoma, or that looks like a fatty aspirate, when you go and stain it, it looks nothing like a lipoma, and it could be something like steatitis. So my advice is, if it looks a fatty aspirate and then you stain it and it looks nothing like the well-differentiated adipocytes that we've seen, it's probably best to send it out. I hope I've clarified that question for that person. Right. I hope so. Okay, let's move on to case 5. Is that a yes or a no?
Yeah, we can move on. The person said thank you.
Brilliant. Okay, so case 5 was an enlarged lymph node and no further history was provided. And this is my little nudge to everyone out there, that actually providing history is really, really useful when you're evaluating cytology. So it's just my little nudge to give us a little bit more history on your submissions. My not so subtle way to reach out to you and get you to submit full history. So this case was another case where there's uneven distribution of the well-preserved cells. And this is really common in lymph nodes, because we often get a really high cellular sample from lymph nodes, but they're often hard to make smears that are of good quality, because they're either too dense or the cells get ruptured too thick. So again, I've given a couple of tips on how to look for good quality smears for lymph nodes. And remember that I learned to do them with that cover slip, but I don't recommend people doing it like that. So when we have areas like this, where it's even cracked, this is again those areas that are too thick for us to look at. So this is going to be impossible for us to look. And often, if we go and look with a higher magnification in these areas, we're going to see all of the nucleoli looking back at us, even if they're not really there. And this is because it's so thick that there's not enough stain to reach all of the nucleus or all of the cell. And so we just have uneven staining, and it may mimic that nucleoli. So here I'm going to have to go and look at these edges to look for areas where it's more spread out. Okay, so just we have to search for these really more spread out areas, but we must remember not to look at ruptured cells. And this is extremely important in lymph nodes, because those ruptured cells, the nuclei, will appear to be bigger than what they were to begin with. And so if we're looking at these ruptured cells, we might be misclassifying them because we're looking at sizes for comparison. So again, we have to hunt for the areas where it's got good distribution, they're well spread out, and fairly good preservation. And this is where we're going to go into the higher magnification. Okay, so remember, we want to look at those fried eggs. We want to be able to see both the nucleus and the cytoplasm of these cells. And ideally in lymph nodes, the first thing I do is I'm going to hunt for my neutrophil, and I'm going to hunt for my red blood cells for size comparison. So there's my neutrophil, in case you hadn't seen it yet. I have a couple of mitotic figures over here. That's my neutrophil. Let's find a nice red blood cell. There's my red blood cell for size comparison. It's well spread out. And so when we look at this, I'm going to try and compare these cells to the lymphoid cells. So here I have, this is a small lymphocyte just next to my neutrophil. So overall, the size of the cell is smaller than the neutrophil. And if I look to the nucleus should be 1 to 1.5 the times the red blood cell in size. So that's my normal small lymphocyte. Remember that we then use the red blood cells to classify the nuclei of these cells, and for classifying them as large lymphoid cells, we usually say 3 times the red blood cell in size for that nucleus. So the majority of them here are actually large lymphoid cells. Remember, in a normal lymph node, 90% or more of the cells should be the small lymphocyte. So here we clearly have an increase of the medium and large lymphoid cells and a very small numbers of small lymphocytes. Just again, to make that even obvious, this is as big as you'll ever see it. That's my normal small lymphocyte. That's my normal small lymphocyte. That's going to be a medium because it's the same size as my neutrophil. And the majority here are large lymphoid cells. There's also here a mitotic, which is atypical. Just another example, another field in the same. So again, I try to include my neutrophil so we can do that size comparison. And here we almost have to hunt for the small lymphocyte. So here's a small lymphocyte. There's another small lymphocyte on the left-hand side, and a couple at 6 o'clock, there's another one there. But the majority, again, here are large lymphoid cells, so that's characteristic for lymphoma. So slide number 5, the case was for a lymphoma, because we had more than 50% of this monomorphic population of large lymphoid cells. And this in a lymph node is consistent with a large cell lymphoma. Most commonly, when we get to diagnose these cases, they're actually more than 80% are these large lymphoid cells, so it makes it fairly easy. But if we're using this cutoff of 80%, it means that we will have a low sensitivity of lymphoma diagnosis on cytology, because obviously before we get to the 80%, we go to periods where the neoplastic population is 15, 20, 30, and 50%. So using this 80% cutoff will lead to a low sensitivity of diagnosis. So basically for lymphoma, when in doubt, send it out, okay? If it's more than 80% of them are large lymphoid cells, then you can make that diagnosis of lymphoma. But just make sure that you're looking in the right areas. Any questions for that case? We'll move on then. And case 6 was another enlarged lymph node with no history provided. And again, you know, fairly discrete population within the lymphoid population, but not lymphoid, because there's my eosinophil, there's my lymphoid, but all of these populations are not lymphoid cells. So it's almost, again, the same question, find the neutrophil and the red blood cell for size comparison. There's my neutrophil. It was hiding there, size comparison. So these cells are all large, but actually they don't even look lymphoid. This one has 2 nuclei, and there's all of these granulations within this. Same here, and they were all present throughout. So case 6 was a mast cell metastatic spread in a lymph node. And the lymphoid population will look mixed. So a lot of people were saying we have mediums and we have smalls, and that is correct. So there was predominantly small lymphocytes, and there was definitely an expansion of the medium and even some plasma cells. But you also had this population that was not normal within that lymph node. So remember, mast cells can be a part of the normal reactive lymph nodes, but they should be present in low numbers and scattered and be well differentiated, so lots and lots of granules. When we have high numbers of mast cells that are not well granulated, then that is consistent for metastatic spread. So when you're looking for these through the lymph nodes, if you find the population that shouldn't be in a lymph node, that should be raising your alert bells. And again, if when in doubt, send it out. Just confirm that there's nothing lurking in the background. So for lymph node cytology in general, again, don't give into that temptation of going straight into the oil immersion. Make sure that you're scanning all of the slides for non-lymphoid population. And this is one of the things that takes the longest in cytology, is to scan for metastatic spread, be it in lymph nodes or in liver, spleens. If we're specifically scanning for metastasis, it takes some time to be able to do that. So scan everything that is for presence of non-lymphoid population. Then you move on to assess your lymphoid, and when it's present, your non-lymphoid population. Remember to go back to using your neutrophil and your red blood cell for size comparison, and make sure you're not assessing that free ground cell nuclear for size. Don't look at the ruptured cells. They will look bigger. So make sure that you're looking at intact cells in that monolayer, because the ruptured cells will look bigger and they may mislead you into thinking that this is a large lymphoid cell, and it's not. Another example of an enlarged peripheral lymph node where I'm demonstrating exactly that thing, so that we have that population in the background that is definitely lymphoid, and then we have these clusters of cells that are not lymphoid. So again, looking at that population, where's my neutrophil and red blood cell for size comparison. Look that these seem as big as the ones that we were seeing before, but look at the size of my neutrophil. It's bigger. So this is what we need to go and compare it with, because the sizes will vary from slide to slide depending on how it's been smeared. So if we look at that neutrophil for size comparison, now we can see that actually a lot of these lymphoid cells are small lymphocytes, and a big proportion. Doesn't mean that I don't have medium and large, but a lot of these are indeed small lymphocytes. And again, looking at these non-lymphoid populations, we had a lot of neutrophils. Again, they're present in higher number than what is from the blood, and they do not belong in the lymph node. And then we have these clusters of cells that, again, are not lymphoid cells, okay? So we have to pay attention to these things. The cells that do not belong in the lymph node, they're not lymphoid cells. So this was a case of a mixed cell lymphadenitis, so it's pyogranulomatous, so all of these other cells were macrophages. And in these cases, the lymphoid population will look mixed, but still predominantly small. When you have that mixed cell lymphadenitis, make sure that you're searching for organisms, mineral materia, and pigment, and then think, what is this lymph node draining? What might be present here? Case 7, we had case 7A and case 7B, which was just a cutaneous nodule, non-adherent and alopecia and firm. And there were just two different cases of very common cutaneous nodules, so I wanted to present them here both. So this is just a lot of amorphous material. It stains bluish to slightly purplish. This is from a really low magnification. Again, those are my red blood cells there. So this is from a high-end magnification. So when we zoom in, we can see that we have a lot of these keratin scrolls, and I'm sure that we all recognize these from our cutaneous, from our derm tape strips type of thing. We also had some pieces of hair shaft here. That's a little bit of hair growing. And with the oil magnification, we'd seen a lot of this amorphous blue material and the things that I usually call crisps. So they're polygonal cells, they're undulated or rolled up on themselves, and they have no nucleus. So these are anucleated squamous epithelial cells. And they are characteristics of a benign keratinizing lesions. Now remember your fingerprints, because a fingerprint will look exactly like this, because it's just the squamous epithelials from your fingers. So make sure you keep your fingers off the center of the slide, because it will mimic exactly this. So 7A, very common. It was a benign keratinizing lesion. This could be either an epithelial inclusion cyst or a cutaneous adnexal or follicular neoplasm, such as tracheoepithelioma, cantoblastoma. They have these varied ugly names, but they're actually quite benign. They have a really good prognosis, but actually histo is required to differentiate between the two of them. And one obviously is non-neoplastic lesion, and the other one is neoplastic, but it's a benign neoplasm. If there is concurrent inflammation in these lesions, then they should ideally be excised. And I want to put out this warning that when there is inflammation with these lesions, your squamous epithelium can exhibit some criteria that may mimic neoplasia. So again, just to reinforce that notion that when we have inflammation and atypical cells, it is always a let's refer this to the referral lab, because we know that we can get false positives from these types of samples, false positives for neoplasia. So inflammation, atypical cells, always a send out. So case 7b, the same presentation, but actually very different cells. In that background of blood, we had lots of cells that were discrete, so they were seen in isolation. And even when they were more tightly packed, you could see that it was still flat. So it's not the three-dimensional clusters that we have with epithelial cells. So these were round cells. And again, for round cells, remember that we go through that. It's 1 out of 5 location. It's not going to be a TVT. So we need to think about lymphoma, mast cell tumors, histiocytoma, and plasma cell tumors. Again, lymphomas, we should have a really high nuclear to cytoplasmic ratio, so not that much of a cytoplasm, so this doesn't fit. For mast cell tumors, we should have a granulation, so this again doesn't fit that. So we are left with a histiocytoma and the plasma cell tumor. And one of the things that I'm going to go and look at is, do we have a HOF? Do we have a basophilic cytoplasm, really dark, with that zone of paler central area? And it doesn't seem the case here. So when I see discrete round cells that look like the fried eggs, then I think of histiocytomas. Again, let's look at that. Really looks like a fried egg, lots and lots of cytoplasm with a central nucleus and no specific HOF or paler area that is perinuclear. So this was a histiocytoma. Again, when we have these discrete cell tumors, it's a process of elimination. We just need to go through the different characteristics. If it doesn't fit any of them easily, again, this is a refer to the lab, make it someone else's problem. Okay, remember that histiocytomas can be accompanied by lymphocytic inflammation, so you can have a lot of lymphocytes there, but those would be small lymphocytes. And this has been associated with the regressing of the lesion, but we can't really predict how quickly that lesion will regress. Case number 8, it was just a single joint affected, it said, and single enlarged joint, and it was direct smears, which what we usually see. So this is with a low magnification, and immediately I can see that I have a really high cell count. Synovial fluids are usually too viscid to allow for automated cell counts, but we can do estimates of that cell count from the smear. So in a normal synovial fluid, with a magnification of 400, so with our times 40 objective, so the highest dry objective, we usually have less than 3 cells per field. So here, with a times 100, I have way more than that. So I know that I'm going to have a high cell counts. Here we have really increased cell counts. So again, with a bigger magnification, we can see that we have that stippled eosinophilic background, all of those little pink dots there. Again, these are characteristic for high protein fluids and often viscid fluids. And we can see the arrangement of these cells, again, very typical for viscid fluids. The fact that they're all in lines, one behind the other, it's called windrowing, and it's very typical in synovial fluids, but you will find it in anything that is viscid. So if this was a mucocele, you could see exactly the same thing. So again, I'm going to make that very, very recurrent question. If we're seeing here is mostly neutrophils, do we think these are degenerate or non-degenerate? Just do the D or N for answer.
We're getting no's.
Non-degenerate, absolutely. Yeah. I'm so glad, and I really wanted to have this reinforced because there were some people who struggled with this during our session. So it's good to see that it's coming through. So non-degenerate neutrophils, however, because it's a single joint affected, this could still well be a septic process. So again, just to remind ourselves that in synovial fluids, the neutrophils often don't go degenerate even if it is a septic process. So we look at it clinically. Is it a single joint that is affected, or is it multiple joints that are affected? If a single joint is affected, then an infectious process is more likely. If multiple joints are affected, then this is one of the criteria that we use for the diagnosis of IMPA, 3 or more joints with neutrophilic inflammation in them. Okay, so it's really important. Now, one of the things that I wanted to point out is that this would be very typical, and I could have this picture as a sediment exam from a fluid from a cat with FIP, and it would have a very similar picture. So lots of the non-degenerate neutrophils, the proteinaceous background, and then a couple of these macrophages with vacuoles here that we have here. I hope you can appreciate I'm circling a macrophage at the moment on the right-hand side of the screen. So case number 8 was neutrophilic inflammation. Again, that interpretation really depends on history because we're talking about joints, so single versus multiple affected joints, different thoughts in terms of it's likely to be septic or not. Just that reminder again, septic joints and the neutrophils do not appear degenerate, and it's really unusual that we find organisms in these joints even when they are septic, so it's worth sending them for culture. When we're looking at neutrophils, as in all of the previous samples, we need to take into account the amount of blood contamination. It's often difficult to, if the synovial is not very much enlarged, if the joint is not very much enlarged, to not get some degree of blood contamination in our synovial fluid, even for the more experienced people. And finally, for our last case, we had different types of samples. So we have here very much a targeted question, and it was, what's the inflammation present, and think about the differentials. And again, we're looking at smears that were really cellular, but that it was almost, you had to find the right area to look at again. So there were areas where there was hardly any cells, and there were areas where there were so many cells and they were so condensed that you couldn't really identify any cells. So you really had to go and look for areas where the cells are well spread out so you could identify them. And then with those areas with a higher magnification, you were able to see that actually there were lots of granules in these cells, and that those granules were pink or kind of orangey pink. And here we can see the granules on a ruptured cell much easier. And these were, of course, eosinophils. So you had here some neutrophils again, non-degenerate, and eosinophils as well, with the eosinophilic granules. So these are all different samples with inflammation present on all of the examples, but they varied in their number of neutrophils and eosinophils because of this uneven cell distribution. So eosinophilic inflammation was present in all, but it was mostly accompanied by neutrophils. And again, we have to remember the numbers. So we need kind of 85%, 70 to 85% of neutrophils to call it a neutrophilic inflammation, but only 5 to 10% of eosinophils, 20 in cats, BALs or more, to define it as eosinophilic inflammation. So in this case, you had both. You had neutrophils and eosinophils. So we often describe that as a mixed cell inflammation. But then we say, well, with lots of eosinophils, so predominant eosinophilic and neutrophilic components. So it's not that I have all of the inflammatory cells, it's that I have these two cells coming through. So when this happens, we have to think about what are the different sets of differentials that we have for each one of them. And because the eosinophilic inflammation has a more restricted number of different differentials, then that's often where we should go with our list of differential diagnosis. So just a couple of reminders. The first question we need to ask ourselves is the slide of diagnostic quality? Only look at samples that are really of good diagnostic quality. They have lots of cells to look at, the cells are well preserved and they're well stained. If not, again, make it someone else's problem, or even better, go and collect a new sample. First question we ask ourselves, is this inflammatory or neoplastic? Use the organograms that are provided in your notes to guide you through that cytological case. What are the questions you should be asking yourselves when looking at these smears? So if it's predominantly inflammatory, which type of inflammation is present, and can I find the cause for it? And the cause will be different depending on the type of inflammation. If it is neoplastic, does it appear relatively benign, or do I have lots of signs of malignancy? And is it round, epithelial, or mesenchymal in origin? And remember, if there's two of them together, if there's inflammation and atypical cells, then this can lead to false positives for neoplasia. So always make sure that you're referring those cases. Again, when in doubt, send it out. I'd like to thank you for paying attention and for being so participative tonight, and ask if there's any questions.
Awesome. Okay, so we have got one question.
Okay.
So it's, on occasion, when sampling masses by FNA, I get quite a bit of blood contamination. Does this matter when evaluating cytology, and is the smear then useless?
So it matters when evaluating cytology, but the smear will not be useless. It will just be more difficult to evaluate, especially if there's lots of neutrophils in your peripheral blood. So one of the possibilities is that you're using the aspirative technique. So one of my suggestions is to try and, for these lesions that tend to bleed a lot, to just use the stabbing technique, so non-aspirative technique, because you can get really good samples without causing technique. If you are using the aspirative technique, then as soon as you see blood, you stop aspirating, because you lead to greater degree of hemodilution. Hemodiluted samples are not necessarily non-diagnostic. It's just that when we have neutrophils, we have to consider, could these neutrophils come from the blood, or could they come from the actual lesion? If there are more neutrophils than what you usually see in the blood, then that says they were there to begin with. If they're the same amount, we won't know. So we often, when I have samples like that in our lab, we often make a comment saying that, you know, the degree of hemodilution limits the interpretation. It doesn't make it rubbish, but you know, you have to take that into consideration. But I wouldn't say, oh, it's got blood contamination, don't look at it. Never, because you can still have a very diagnostic slide, even despite the fact that it does have blood.